what is the treatment sequence and what to expect in terms of the length of treatment with this type of appliances. So the overall first phase of treatment is always the expansion phase, when we improve and increase the volume of the maxillary bone and the nasal passages. So that might take anything from 1 month, depending on the age of patient, up to 3 months. So starting from there, the appliance has to be activated, and once the appliance is activated to its capacity, or depending on how much we need to expand, usually this does not exceed 3 months. Going on from there, this appliance is left in the oral cavity with no activation, passive and secure. When the enough expansion is achieved, then we start rearranging the position of the mandible and the teeth around with any type of appliance, which is usually either braces or clear aligner treatment. In our practice, we use Invisalign for that purpose. So from then on, the arrangement of the teeth and the bite might take anything from maybe 16 to up to 20 months. So the passive positioning of the skeletal expander takes 6 months, which is a part of the bite rearrangement. So overall, it's going to be 3 months, for example, for the expansion, plus 16 to 20 months for the bite rearrangement, which results into anything from 18 to 24 months of treatment. As you know from anatomy, you might know that the palatal vault is the same type of bone composition as the base of the nasal floor. And based on that, any manipulations, any skeletal manipulations with the bony skeletal envelope of the mouth, which is the maxillary bone, have consequences on the nasal breathing. Meaning that if we increase the width of the palatal vault, that will inevitably increase the width of the nasal floor, improving the passages and the volume of the nasal airway passages. So that, of course, improves the amount and the volume of air coming through the nose. The position of the tongue is of the utmost importance, because if we improve the nasal breathing, the position of the tongue and the habits that evolved during the previous years may impinge and may decrease that airflow down the airway passages. So the treatment must be focused on both the improving and increasing the airway space in the nasal passages, as well as the positioning of the mandible in such a way that the tongue musculature and the overall positioning of the jaw do not interfere with the airway flow in the oropharyngeal area. So we're looking at improving and increasing the volume of the airway within the nose and within the oropharyngeal airway, which is particularly and directly affected and caused by the position of the mandible with the surrounding musculature of the tongue and the position of the tongue itself. So there are several factors that affect the airway flow, and something that I'm talking about during my consultations with the patients. First of all, we improve the nasal breathing with the different types of skeletal expanders. And the second thing is that we differentiate the position of the mandible, and we see if we really need to forward the position of the mandible, of where the tongue is positioned. Is there any restriction for the tongue movements? Namely, is there any tongue tie? Should that be addressed? Can that be addressed with a myofunctional therapy, or should it be addressed with the surgical intervention? So all these questions are asked and are covered during our initial consultation that we offer to our patients in Boca Raton. What am I looking for when I decide on a specific type of appliance during our consultation with the patient? First of all, I'm looking again at this dimension right here in the deepest part of the palatal vault, because I have to insert my mini screws right in this position, which is the closest to the transition between the hard and soft palate. This is the highest point. I also need as much bone anchorage that I can gain. You see this, this patient has a lot of shrinkage in her palatal mucosa, and this patient has also a lot of folds in her palatal mucosa. So this will be a type of concern. So in this patient, when we look at her CBCT, then we have to decide if there is enough bone to include in positioning of our screws for any type of skeletal expander. The second thing I'm looking at is these anchorage teeth. Are there any crowns? Are there any bridges? Is there enough support to carry the appliance? And what is the amount of expansion we can do? For example, we have good molars on both sides. We have some crown work right here, so I would not place any type of bands or any type of covering on the premolars. I would rather put a type of arm right here because I still want to have expansion going to the sides and going forward, I mean mesial to the back molars. So that's going to be another part of our design. And the best question and the most important question, will MSE fit in this patient? This patient, having had that she is in her mid-30s, is not a good candidate for the MSE for several reasons. First of all, she doesn't have enough bone support in the palatal area. Second thing that bothers me most is that will this patient predictably open? Won't I have some molar movement instead of having her palate opening with a true skeletal expansion? I want to avoid molar movement, molar tipping as much as possible, which is the adverse effect of any type of skeletal expansion. And this is something that we cannot avoid in any case. That's why after providing the treatment for the skeletal expansion and after having everything open, we have to take care of those that excessive molar tipping. This is always the case with any type of skeletal expansion, that around 30, maybe sometimes in some type of expanders, even up to 50% of expansion is attributed to molar tipping rather than having it a true skeletal expansion. What would be enough expansion in this particular case? First of all, we have to achieve our most important goal is to correct this crossbite on either side, and going with the skeletal expansion that will cause expansion on both sides, so that has to be accommodated on the lower jaw as well. Second thing, how far should we go? First that we're looking at is the width of the bases of both jaws. So the width of the actual bone embracing for the teeth here in these areas and in the posterior molar areas. How wider is the molar, is the lower bone compared to the upper bone. And based on that, we can see, of course, measuring with the CBCT, we can measure how much of a camouflage lower molar tipping is here that compensates for the upper narrow jaw. So if we imagine that we upright lower molars, how wider this side and this side would be. If we decompensate this case, if we straighten up these back molars, how wider the lower becomes. Based on that, this is the first consideration. The second consideration is how much patient wants to have her improvement in terms of breathing, because one of the most important things and problems that our patients come seeking this type of treatment is to improve their breathing, which is directly associated with the width of the maxillary bone and the base of the nasal cavity. So when we decide on the amount of expansion in this type of patients, it's also the patient who gives us the feedback on how much they want to have their bone and they have their nasal breathing be improved. If they still need more, if they still want to have more improvement and more airway volume within their nasal passages compared to the condition when they first came in, or this type of consultation.